All right, welcome everyone. As I think most of you probably know, I'm Amanda Egan, the Director of Patient Engagement and Clinical Programs with the RUNX1 Research Program. Oops, apologies. Okay. We are delighted to have here with us today Dr. David Young. He's the Clinical Director of NIH's RUNX1 FPD Natural History Study, which you're about to hear more about. Dr. Young was trained as a pediatric hematologist and oncologist, and he's also a staff clinician with the National Heart, Lung, and Blood Institute, one of the other institutes within the NIH, where he conducts early phase clinical trials for the treatment of bone marrow failure diseases. And he has been studying bone marrow diseases like RUNX1 FPD, MDS, and leukemias in the lab since 2002 and has been treating patients since 2011. So patients are in great hands when they visit the center. So this study itself has been instrumental in helping us deepen our understanding of RUNX1 FPD, benefiting the whole RUNX1 community, including scientists, clinicians, and patients themselves. So thank you to Dr. Young and his team for conducting this study, and to the many patients who have enrolled and either traveled to Bethesda to participate, and in many cases, several times, as you'll see, or have had their doctors send in tissue and blood and other records to be part of the study. So today, Dr. Young will provide an overview of the study for those who may be less familiar with it, but he'll also share some initial trends that the team is seeing from the data that they have. So we feel it's really imperative to keep participants and other patients up to date on what's being learned, and we appreciate you, Dr. Young, being here to offer this update. So just quickly, I'll cover a housekeeping item. As you'll note, we are on webinar today, and that's so that we can support anonymous participations so patients can feel most comfortable. So in that case, we won't be able to see or hear you, but please use that Q&A icon at the bottom of your screen to type in questions at any point through Dr. Young's presentation. And at the end, he and I will go through as many of those questions as we can. And note that you can also mark your questions anonymous so that we don't see your names, but we will not mention your names regardless. So it's up to you how you'd like to do that. And okay, I'll let Dr. Young take it from here, unless you have anything to add to that. Yeah. All right, thanks, Dr. Young.
All right. Well, thank you, Amanda, for that lovely introduction. And it is my pleasure to be here today to discuss the updates to the RUNX1 natural history study that we are conducting here at the NIH. For those of you I haven't had the pleasure to meet, I'm a relatively newcomer to this. I joined the team during the depths of COVID. This was a project that had started just around the time that I joined the NIH itself, back in I believe it was 2019. But it has been my pleasure for the last few years to actually take over from Dr. Cunningham, who really laid the groundwork for a lot of this with some of the other members of the team, and to serve as the medical director and be the one that gets to sometimes be the face of what is a very large project, and has been a very great collaboration and quite fruitful. And we'll discuss a little bit about what we have seen since I last talked to everybody about a year ago. I do like to start, and this is a framework that I actually have to give credit to Natalie Deutsch, our genetic counselor. I do like to start with a little bit of an overview, because we are a diverse group of people, and I never know exactly where everybody is in terms of both their RUNX1 journey in general, understanding genetic diseases and things like that. So I do apologize for those of you that some of this looks a little bit familiar, but I'll try to move quickly through it so we don't waste too much time. But I want to make sure that we are all on the same page. So RUNX1, familial platelet disorder, or FPD, or RUNX1 FPD, and sometimes even called FPD-MM, but for simplicity's sake and the sake of my tongue, I'll simply call it FPD, is a disorder that arises when a gene, specifically RUNX1, gets misspelled. The genes, as most of us probably are aware, going back to our biology days in high school, contain all the information that is needed to make a person, and it's all found within the DNA. And in fact, it comes down to 4 letters, A, G, T, and C. These letters spell out all the words, which are the genes themselves, that explain how to build a body and run the body. And from these words, our cells make the various proteins, which are the next step, and that's where I think the analogy breaks down a little bit. But the proteins are what do the actual work of the body. And so everything in the body is either a protein itself, encoded directly by a gene, or is made by a protein that was encoded by a gene. So RUNX1 itself is actually a fairly large gene. It has about over 200,000 letters, about 250,000 letters. And of those, over 1,400 are actually important to spell out the protein itself, and other parts of that, the RUNX1 gene are involved in how regulating when and how it works. As a cell grows and divides, it can sometimes miscopy its DNA, though. And as you can imagine, when you're copying 250,000 letters, or the billions of letters that make up our entire genome, occasionally a mistake that happens. And any cell that comes from that original cell will have what we call a mutation, which is a misspelling of that word, that gene. And these mistakes can be passed down to children, which we call inherited. So that is why we call RUNX1 an inherited disorder. Now, these sometimes can happen within the cells that don't get passed down, and those are the non-inherited, and that will come up later again, and it's important. But when there is a problem, when there's a mistake in the genes, it affects how RUNX1 itself works. And RUNX1 is a transcription factor, and I'm not going to get too deep into what those are, but it's best to simply describe those as master regulators of the cell. The transcription factor is involved in putting together all the signals that the cells are constantly receiving to make decisions. They control when, where, and how much of other proteins are made. They determine what the cell is going to do. Is it going to grow? Is it going to change? Is it going to carry out different programs? And even sometimes will the cell itself die, because that's also an important part of the cell's life. And oftentimes transcription factors themselves regulate themselves. So you get what we call feedback loops. And in RUNX1 FPD, the RUNX1 protein is either damaged, it's reduced, or in a good number of patients, it's completely lost altogether. Now, we have two different copies of most genes, almost all the genes in our body, but a lot of times when we lose even one of those copies, that only having half of the normal amount can be sufficient to cause changes that lead to disease. So how does RUNX1 affect the blood? Well, this is actually a picture of what it would look like if you looked under a scanning electron microscope, that's the black and white pictures, or if you looked under a regular microscope, and that's the color pictures, of both the blood from an unaffected person or a person who has RUNX1 FPD. There's a couple important points to notice. In these little, the platelets, they all contain these little dots, and these are sacs. And there's different types of them, and we won't get into exactly what they are, but they contain the various factors that are necessary for making clots, and which is the primary function of the platelet itself. In RUNX1 FPD, there are changes to these granules. Sometimes they don't have them, sometimes they're missing, sometimes they're misshapen. And as a result of that, the platelets that are formed don't function quite as well, and sometimes not at all. So when you have a cut or a bruise, you bleed more or bleed a lot. Importantly, platelets themselves are not actually cells. They're pieces of cells that are made by larger cells called megakaryocytes, which you can see pictures of in the color photographs here. Usually they are giant cells that make lots and lots of platelets. But in RUNX1 FPD, you can see they don't look quite the same. They don't have all the little same shapes to them. And importantly, they don't make as many or any platelets at all. So the end result of all this is, in RUNX1 FPD, you have fewer platelets, and the platelets that are being made don't function properly. Now, it's important, as I mentioned, that RUNX1 is a transcription factor, a master regulator. And so while it's very, very important to platelets, it actually controls a lot more in the blood than just platelets. Blood itself comes from the bone marrow, and this bone marrow stem cells give rise to all the different blood cells that we see in the circulation. There's the white blood cells that fight infection, the red blood cells that carry oxygen, and of course the platelets that do clotting and healing. RUNX1 FPD affects these cells too, because the RUNX1 protein is important in regulating these cells as well. It's not quite as central, which is why the main change that we see in RUNX1 FPD is the platelets, but there are other effects. And the important part to understand is that the stress that results from these changes in one part of the bone marrow can affect other parts, leading to inflammation, anemia, which is low blood, and that can be either because you're bleeding too much and losing the blood, or because your body's not making blood. You can also have infections, and of course, the big concern that everybody has is cancer. But even beyond blood, through the work of this study, as well as the work of other researchers, we found that RUNX1 controls a lot more than just the blood. And so patients who have RUNX1 FPD can have other issues. And a lot of people who have come to visit us over the years have told us a lot about some of these other issues. And these can range from just some abnormal blood counts to things like allergies, to autoimmunity, eczema. We see a lot of migraines and headaches. We see gastrointestinal issues. We even see some developmental disorders where the body doesn't form properly. And there are other things that we're constantly learning about, which are difficult to tease out because there are a lot of things that go into making a human being. But we are beginning to understand that RUNX1 is important in a lot of those things too. And so RUNX1 FPD maybe doesn't affect everybody in the same way, which we'll discuss a little bit, but does affect a lot of different parts of the body. So as part of trying to understand that, we have put together what is the RUNX1 FPD clinical research study, often known as the natural history study. You can see the full name there. But basically, our goal at the NIH, and you can see a lovely picture of the NIH Clinical Center that all of you will get to visit whenever you come to visit us, is to understand what it is to have RUNX1 FPD. What does it mean for your blood? What does it mean for your general health? What does it mean for your life? What does it mean for your family members, for those who have RUNX1 and for those who don't? And of course, what does it mean for any children that you might have further down the road? And the goal really is to bring together as many people as possible at the NIH and to really learn as much as we can about it. And really, at the end of the day, the superstars here, although we have done a lot of work as a team, are really our patients who have really come together and taught us so much there is to know. And we're learning every day more and more. For those of you on the call who maybe haven't been to the NIH, what is the natural history study? Well, it actually gets done in several different phases. The first phase is the remote enrollment. And that is either you, your doctor, or somebody realizes that you have RUNX1 and reaches out and contacts us to say, hey, we have someone new who has RUNX1 who hasn't been seen before. You might want to learn more about it, and they'd like to learn more from you as well. And what will happen is we have the remote enrollment where you will sign some paperwork, which allows us to start the process. You'll talk to somebody. Usually it is Natalie who will be reaching out to you. Sometimes it's Katie or one of the other members of our clinical team. And that will gives us permission to talk with you, to get more information about you, your history, your family, and to also, more importantly, gain the medical records that will help us to start to understand and put together the parts of your story that is RUNX1 FPD. For people where we think there might be RUNX1, but we don't know, either because they've never been tested, but they have a history of it, or there are family members who are affected, but they have not been tested, we can also send out kits and things like that to allow us to do cheek swabs that will allow us to then test for RUNX1 and decide whether or not you are someone who does have RUNX1 or not. We can even occasionally do blood work at your doctor's office and have them ship it in. And we can do it, and then oftentimes there'll be a phone call and things like that to get to know you a little bit better. But really the meat and potatoes of this study is the work that happens when you come to visit us down in Bethesda at the NIH Clinical Center. And it usually is a several-day visit. We try to tailor it to fit your schedule. We try to tailor it to fit your needs. And sometimes it can be longer if there are more things that we're worried about. Sometimes it can be shorter if your time is limited. We try to respect that because we recognize you are doing this voluntarily, and we appreciate that greatly. But usually it consists of a few days, and over the course of those days, we'll get to meet you, we'll get to learn a little bit about you, we'll do some blood work, we'll make sure there's no concerns or anything that we need to do before we move forward with more advanced testing. And we'll have you meet with any specialists or other doctors who might be able to address some of the other issues that are going on in terms of your RUNX1 FPD, or even just your general health if there are things that we are worried about. Usually on the second day, although sometimes on the first day later in the afternoon, we'll do a bone marrow biopsy. And we can provide various levels of support for that to help make sure that you're comfortable. Obviously, there's going to be some discomfort associated with the bone marrow biopsy, but we want to make it as painless and as easy a process as possible for everybody who comes to visit. And then, of course, there's also the opportunity to meet with other doctors if you had got a chance to meet with them earlier in that day. Usually that day is pretty much devoted to that because it is an intensive process. And especially those who might be undergoing sedation, there is a little bit of recovery after that. And then on the final day, you'll meet with the rest of the team. That includes myself and other members of our clinical team, as well as some of the researchers who are assisting the clinical team. And during that time, we'll sort of wrap up what we learned at that visit and begin the process really of learning more from you. Because what will happen is after that period, over the next weeks to months and even up to a year, we'll be continuing to get back some of the information that we collected from the data, samples in the data and the tests that we ran at that. So it is actually an ongoing process, even though the visit itself is only a few days long. And as that information comes in, we make sure to share it with you, with your doctors, and with anybody else who might need that information and who might be affected by those results. Ideally, because this is a lifelong process, because this is a lifelong disease, and because we're constantly learning more and want to learn more from you, this is something that's repeated annually or every other year, depending upon how things go. But it's important to note that, as Natalie and Katie like to call it, this is a choose your own adventure participation. We would love it if we can get everything we can from you at your visit, but there might be restrictions, either because of your health, because of concerns about certain things, or just because your schedule doesn't allow, and we tailor your visit to really reflect that. It's important to mention, too, that you travel within the United States. All lodging, all procedures, and all testing are covered at our expense, and you should not be responsible for any of those testings. We have plenty of patients who are coming from internationally. Unfortunately, we aren't able to cover international flights, but once you make it to the United States, we are able to cover all those expenses. Now, there is a little bit of confusion sometimes between the RUNX1 natural history study and RRP. And I want to make sure that everybody's aware of the two groups. We are separate groups, but we all have the same goal, which is really education for patients and their medical teams about RUNX1 and learning as much as we can about RUNX1 FPD and how it affects people and hopefully how we can treat and manage it into the future. At the NIH, we really are focused on clinical and lab research, both at the NIH itself and with collaborators. We do have some subspecialty care and clinical testing, again, as I mentioned, at no cost. And we are trying to serve as a central repository for specimens that we collect from patients when they do come to visit us. We do manage partnerships, and we maintain probably the most powerful thing that we're able to do at the NIH is these long-term longitudinal studies where we follow people for years, which is not really something that's able to be done in a lot of institutions because of the way those institutions are set up. The RRP at the same time is somebody we look to as an important collaborator, and it's someone that we've worked with for several years, and we love working with them because they often serve as a connection to the RUNX1 community, and they serve particularly in supporting research collaborations, setting up networks, helping to connect patients with each other, with physicians and researchers, and even helping to drive funding and set goals for future research directions. They do provide a great network that we've tapped into ourselves many times of specialist hematologists and other providers. And particularly important, there's now an ongoing process to develop consensus guidelines that will help us to establish the standard of care for people who have RUNX1 FPD. So what have we learned from the RUNX1 natural history study here at the NIH? Well, when we met last year about this time, we had literally just put out the first publication from the natural history study, which you can see shown here, which was a collection of our experiences in the first 100 or so patients who had RUNX1 FPD who came to the NIH and who were evaluated. Since that time, we've actually put out another major publication that came out earlier this year, where we examined the genomics, the various changes and the various ways that our genes interact to affect RUNX1 FPD. And I'll be discussing some updates to the natural history study as well as talking a little bit about what we learned from the genomic studies. Both of these are, I think, very powerful studies that were only possible through your voluntary participation here. We do get a lot of questions. We try to answer those questions. We still get a lot of those same questions because a lot of you have similar things on mind. Things like, how long are you going to be doing this for? When will it be done? When will we learn anything? And this is all an ongoing process. And we are learning a lot from you. Hopefully, we are teaching you guys things too about your disease as we bring all the people together. And it is our goal to always feed that information back to you and to the rest of the community and to the doctors and nurses and people who take care of you. And so some of the same common themes keep coming up over and over again, especially things about like bone marrow biopsies. How often do I need them? What should I be monitoring and what should I be looking for, and how can I make RUNX1 FPD? We're starting to get new questions too as our cohort of people that we've been following it expands and grows in ages too. Things like, what do I do if I'm pregnant or want to have children? What do I do about my children who might have RUNX1 FPD? We are now seeing people actually growing up in the study, and this is actually helping us to understand the lifelong implications that RUNX1 FPD has. So we like to always give the numbers. So who is in the natural history study? Well, it continues to be a growing history, a growing community. We now have over 600 family members identified out of almost 150 different families who have been referred to the program. But it's not just a large community of people. There are a lot of people who have actually now enrolled. And enrollment, as I mentioned, is choose your own adventure. And enrollment can be you talk to us on the phone and we get a little bit of information and we follow you remotely, or it can be the full experience of coming here to the NIH. But we have over 450, almost half a thousand people have enrolled in this study and are giving us actively information about RUNX1 FPD. Of that, about 200 patients have RUNX1 FPD, and about 200 are their family members who we don't think are affected by RUNX1 FPD. And we are learning much from both groups of people, both what it is to have RUNX1 FPD and what it is to live with someone who might have it, but not to have it yourself. And it also teaches us things because things run through families. And so we can see, is this RUNX1? Is this something else? We have a lot of people who have come to visit us. We have almost 180 people have now come to visit us, but not just visit us. Over 100 people have now had bone marrow biopsies, and that really is such a valuable resource to learning about RUNX1 FPD. And we recognize that having a bone marrow biopsy is not a small thing by any stretch of the imagination. But not only have we seen a lot of people and met a lot of people, but we've met so many people so many times. You are a committed community that keeps coming back. And even though we've had 100 people plus come to visit us one time, at least, we have now had almost 70 people who have come down for multiple visits. And that includes a handful of people who have been here 6 or 7 times. And each time you come, we learn something new. We see a little bit more about how RUNX1 affects you through your lives. And this really has been helping us to learn more and more about what it is to have RUNX1 and to live with it. Now, those of you who are quick will have noticed the numbers aren't quite adding up. And that's because we have also a small group, probably about 57, though probably larger if we were to dig a little deeper, of people where we don't know. Maybe you have RUNX1, but we don't know if it actually is an important mutation, or maybe you don't have RUNX1 and we haven't been able to identify whether or not you have a mutation in RUNX1. And that leads to an important point. Not all mutations are the same. You can see, going back to our analogy of misspelling, there are different ways to have a typo when you're typing something up or when you're writing something out. And sometimes some of those misspellings have different changes than others. Sometimes they completely distort or destroy the meaning of the sentence, just like a mutation completely distorts or destroys the function of a protein. And other times, those mutations don't cause any changes, at least changes that we can say. And this is how we have different mutations can range from what we call benign, which are mutations that are there and we can detect but don't cause disease, to pathogenic, which are mutations that we know cause disease. And the effect of any given mutation can range from either mild, moderate symptoms, so on the benign end, but maybe it is causing having effects, to very severe disease. And we've seen this whole spectrum in all the people who have come to visit us. But equally important, there is, and as many of you know, a group called the VUS, or the variant of unknown significance. And this is similarly a mutation. We can see the change that happens in the DNA, but we don't know what impact it has on RUNX1. Some mutations are very obvious. They break the gene, it doesn't work. Others are a little bit more subtle, but we can say, oh, but that's an important part of the gene, and by changing that, you are affecting it. But there is a good number, and we've been on the journey with a lot of you as we try to sort this out, where we try to understand where on the spectrum do these variants settle in, and what does that tell us about what that mutation means for you, for your disease, and for your health and the health of your family members. A lot of the work that particularly Kat Menezes has been doing in our group has been really trying to sort out what is an important mutation, whether that mutation is pathogenic or benign. And through our work in our lab, as well as many of our collaborators, new tests and criteria have been developed to do what we call calling a mutation, where we assign it into one of these two bins. But we have to still answer the question, do all pathogenic mutations have the same significance? Maybe it disrupts it, but maybe the disease isn't terrible. Maybe what does that mean for your cancer? And equally important on the other end, can there be benign mutations? We can see the change. It causes a change in the protein, but we can't necessarily see it using assays, for example, like the one shown here. We don't see necessarily the effects. But when we look at the patient, we say, well, but it seems like something's going on. And so what do we do with these supposedly benign mutations that might still have clinically important effects? And most importantly, and as I said, this is something that we've been on a journey with several of our family groups with. What do we do with someone with a VUS that we just really can't find? And you can see as we look at this assay, we have the mutations that fall in the green range. Those are the ones that are probably benign. The ones that fall in the red range, where they've lost most of their activity. But there's that middle range. And they're in maybe they are in the benign range, but we think, oh, there's something going on in this family. They've been bleeding or they've had lots of cancers. And you folks have taught us so much. This is what we had just this time last year when we published our paper showing RUNX1, that's the line across the top, and each of these little indicators shows a different mutation that we found in RUNX1. Since that paper has been published, however, you've all been visiting us, and we've been filling out even more and more and more. And we've nearly doubled and probably almost tripled the number of different mutations and variations that we have found in RUNX1. And we've been able to characterize a lot of those, and some work is ongoing to characterize even more of them. But it's telling us so much more than we ever thought we would ever know about what RUNX1 looks like. And this in and of itself is just a major testament to the dedication and the volunteer spirit of the people with RUNX1 who have come to visit us. Of course, there is the big question with RUNX1, cancer. Who has it? Who's at risk for it? And what can we do about it? In our cohort, there are a lot of people who have had cancer. Of the people who are officially enrolled on the study, over 70 patients either had or have had blood cancers at some point in their life. If we expand that to our even further, looking at the extended family members, people we maybe haven't met, but people who other family members have reported on, we've been able to identify of at least 170 individuals across the different families who had a blood cancer that was likely related to RUNX1 FPD. And in fact, what we found is as we have more people with RUNX1 in a given family, we see more cases of blood malignancies in that family, which shows that there is a linkage between RUNX1 and cancer. To the point that almost 2/3 of the families that we have seen are families who have blood cancers. And and it's quite possible in the 1/3 of the families that we haven't found blood cancer in, we either haven't looked far enough back, we're missing information, or it may be that it's a rare case where RUNX1 has just developed new in that family, and there just hasn't been time. So we do realize that there is a high risk of cancer related with RUNX1. And when people ask, we say it's about a 30 to 50% lifetime risk of having cancer. And this is a lifetime risk. It's not a 30% chance that people will develop cancer tomorrow. It could be tomorrow. It could be years from now. And this is a difficult problem because that means that this is something that will hang over people for very long periods of time. And we are aware of that. And one of the biggest goals that we wanted to look into is how can we identify people who are at the greatest risks of having that, and what can we do to either watch for it and maybe intervene before it becomes a problem. And as I said, it goes through families, but it doesn't always go evenly through families. We see it sometimes skipping generations. We see sometimes every family member can have it. But it does come back down to what kind of mutation do you have? Fortunately, most of the people, as I said, most of the families, I should say, have been able to be placed into one of these bins in terms of whether or not it's benign versus pathogenic. And when we look at specifically the patients themselves, what we find is most of the people who have cancers are coming out of groups where it is either known pathogenic mutation in RUNX1 or a likely pathogenic mutation in RUNX1. So we're pretty sure it's pathogenic. It just hasn't quite reached the criteria needed. But there are people who fall into the VUS group where there is cancer as well. And this is probably more cancer than we would expect to see in just the general population. And so it's important to remember that just because your variant is called VUS doesn't necessarily mean it's not doing something. It just means it hasn't reached the level where we can confidently say it's disrupting RUNX1. And so there's still risks that may be associated with having a VUS. And these are people who probably should be monitored closely too. And on the other side, people who we think are benign or we know are benign, we don't see the cancer nearly at the same instance. Going back to, it is very important for us to be able to identify whether and what kind of mutation you have. Now, it's not just the mutations, though, that you're born with that we're studying. We also are looking at what we call somatic mutations. These are, from a standpoint of the DNA, the same kind of changes that we see with the changes in RUNX1 that you inherited, but these are changes that happen as you age, and they happen naturally to everybody as we age. Importantly, they can't be passed on to other family members, but they may tell us something about the cancer and the risk of cancer within a given person. It's important to remember that blood cells are turning over millions of times each second. You are literally making billions of blood cells every minute. And during that turnover, all people acquire a mutation here or a mutation there. And as we get older, those mutations do start to pile up, and sometimes they can lead to disease. But what's interesting is that in RUNX1 FPD, we see certain mutations, certain genes get mutated more frequently than others. And these aren't necessarily the genes that we see more commonly mutated as someone ages, which might tell us something about the RUNX1 FPD. And this actually leads to a condition called clonal hematopoiesis. And it's a condition where either a single cell or a small number of cells, a clone as we call it, with a somatic mutation produces most of the cells, blood cells that are circulating in the body. And this can have a couple implications. Sometimes these don't produce blood as well, and so your blood counts may fall. And of course, sometimes these mutated cells, because we're relying so heavily upon them, can go even further awry and lead to further disease, such as cancer. But it raises questions. Why does RUNX1 FPD seem to prefer these specific mutations? And what do these mutations mean for the risk of cancer and other complications? When we look at clonal hematopoiesis in the general population, we know the acquisition of certain mutations can be a harbinger of the likelihood of developing cancer later. And other mutations, though, are just an indication that the bone marrow is getting older as the patient ages. Which is which, and what can we say about those, and can we do the same with RUNX1 FPD? Well, as I mentioned, we do see slightly different mutations in RUNX1 FPD, and the two by far most commonly mutated genes are BCOR and TET2. And you can see here a list most recently updated by Amra in our lab, who is one of our postbacks, where we analyzed all the different mutations that we see in these genes. We see BCOR mutations in about 1 in every 5 patients with RUNX1 FPD, and we see TET2 a little less frequently, maybe 1 in 6. And there are even patients with RUNX1 FPD who have mutations in both. Sometimes there are multiple different mutations, sometimes it's just one large mutation, and sometimes they can be changing, coming and going, or other times they can remain unchanged for many, many years. What does this mean, and how can we interpret these things moving forward? In the paper that was published last year, we looked at all the mutations, and this is sort of a heat map, and I'm not going to go through it in detail, but what we found looking at it is that about half of FPD patients have a mutation in what we call a myeloid gene. And these are genes that are commonly associated with clonal hematopoiesis. That is much more than we would expect from the general population. And it also seems to be happening at a younger age than the general population. But the associations have been few. Which RUNX1 mutation you have does not seem to affect which somatic mutations you acquire. So whether it's in BCOR, TET2, or one of the other genes that we find. Somatic mutations were just as common in patients with cancer as those without it. So just because you have clonal hematopoiesis doesn't necessarily mean you're at higher risk or at imminent risk of developing cancer. And no specific mutation has yet been found to be at a higher risk of having cancer. So acquiring these specific mutations or these genes being mutated is a guarantee for developing cancer. Probably the most important thing what we have found is that if a mutation does develop and then we see that clone grow as it takes over more and more of the blood, that's probably the biggest and most concerning sign. But as I said, we can have several patients who have large clones that actually will then remain stable for years, if not almost a decade or so. And so these are things that we're still trying to understand. But then it leads to the question of how often do we need the biopsies? And I want to show this graph on the right. It's a little bit old and we have new data, but it's probably the cleanest one we have, where you can see that there are two different groups of people who are at risk for developing cancer. Sadly, unfortunately, it's not common, but sadly, there is a small group of people who will develop cancer early on in life, either shortly after birth or usually before they reach puberty. And as a result, we do worry about children who have RUNX1 FPD, and they are people that we want to keep a close watch on, especially once they reach an age where we can start doing bone marrow biopsies safely. Then things seem to quiet down a little bit in the middle of life, but then the risk of cancer begins to go up again. And this is actually reflects what we see in the general population, where risk of cancer does increase as we get older, but it seems to happen at a younger age in RUNX1 FPD. We're still looking for any mutations or signatures or blood work changes that might predict progression. But really, right now, bone marrow biopsy remains the gold standard. And it really is our recommendation that beginning around 3 to 4 years of life, earlier, if there are changes in your blood counts, you should be getting a bone marrow biopsy about once a year. And then if things have been stable for 3, 4 years or so, maybe we can hold off and do it every few years. But then as you begin to age, especially as you reach an age where other people in your life may have been having cancer, you should be getting bone marrow biopsies more frequently again. We are looking for ways to break people down into high risk, standard risk, low risk. This is something that has been done with other diseases. We haven't really reached that point yet, but we continue to look for that. And the more we meet people, the more we learn about your disease and learn about other people with RUNX1 disease, the better we are able to really define what we should be looking for. And so again, you guys coming to visit us has been very, very critical to help us get a sense of what is normal and what is not normal for RUNX1 and who are the people we need to be watching more closely. And again, we thank you for that. As I mentioned, it's important to establish a baseline early, monitor annually, and then if you are stable, every couple of years. But in the meantime, we really do recommend people be getting blood work at least once or twice a year, maybe more frequently if there are anything's going on or if there are any changes that are happening. And as I mentioned earlier, RRP is coordinating a consensus statement in which all the experts across the world are getting together and we're discussing what we think is the best ways to take care of people with RUNX1 FPD. And this will allow us to really establish the guidelines and the standards of care, which can have implications both for the ability for us to make sure we're giving everybody the best care possible, but even sometimes can lead to the ability for us to get insurance companies and other people to pay for that testing, which can be a big barrier to care. But we're not just looking at that. We're looking at all sorts of things. This is a very busy slide, but it's really busy to show you just all the data that you guys are providing us every time you come to visit. And it really is helping us to understand what is normal for adults and for kids. And they're not the same. We are learning the differences between children and adults with FPD and without. And so we also thank our healthy family members who come to visit us too, because you're teaching us so much as well. And it's also beginning to help us understand what might be a warning sign. When we see a certain count or a certain parameter change, could that be a sign that maybe we need to be doing bone marrow biopsies and watching a little bit more closely? And again, we thank you for that. From your standpoint, we don't recommend you get a blood count every couple of weeks. That's too much unless something's going on. So what should you be looking for? Well, you should talk to your doctor if you ever have worsening bruising or bleeding. That's obviously the most common concern that anybody has. And the CBC remains the most important clue that something could be going on. And it's a relatively simple test, and it's a relatively quick test. But if you have issues with fatigue or exercise intolerance, frequent infections, if your skin colors are changing or your eye color, if abdomen, weight loss, weight gain, and recurrent fevers, these all could be signs that something has changed and is a reason to talk to your doctor and to get better, to be worked up a little bit more. Can we change your disease? Well, we're looking into that. There's a lot of questions about healthy lifestyle choices, and it's important to live a healthy lifestyle because both it will no doubt have good important impact on you, but also if you are healthy and something does happen, it makes it easier to treat. And it's also important that you remain connected with a hematologist. Most of the people who come to visit us are coming through a hematologist referral, and you've all been working with some wonderful hematologists. And if there are anybody on this call who isn't associated with a hematologist or blood doctor, we would recommend you get connected soon. And we are happy to help, and the RP also is happy to help make recommendations if you can't find anybody. What is coming up though? Clinical trials, some, as I mentioned, the consensus guidelines, which you're all very excited about. And we are looking at things like gene therapy, but unfortunately that's not quite there yet, but we are working. One of the big questions though that we get is, what should I do if I am or plan to become pregnant? And this is actually a question that we just started looking at. It's particularly Natalie, our genetic counselor, has been looking at it in collaboration with a an OB-GYN who works here at the NIH. And what we have found is there have been many successful pregnancies in the natural history study. 37 different women have given birth while either on the study or prior to coming to our study. And there have been 91 healthy deliveries. There have been, sadly, miscarriages and complications that have happened in pregnancy. But the important thing to understand is, as far as we can tell, and we continue to look to get a better sense of it, miscarriages do not appear to be more frequent in RUNX1 FPD, which means that if you are thinking of having a child, this is something that you probably can do carefully, but successfully. Bleeding is a concern, not surprisingly. Bleeding complications, both for the mom and for the baby, are common. They are more common than would be in the general population, and that's not surprising, but they can be managed with platelet transfusions and either using Amicar or Lysteta. One of the things we have identified is epidurals don't seem to be used as much for women when they're giving birth, and they may be underused, and we are looking at ways to safely use epidurals so that women can get the relief and comfort that they need while giving birth. But it's important to note that pregnancy requires a multidisciplinary approach, and you should begin planning with your doctor early for the best results, both in terms of how you plan to get pregnant, whether or not you'll be using any sort of genetic testing prior to or after conceiving, and then the plan for when it is time to give birth. Natalie has been working tirelessly along with some of the other members of our team, and we now have educational materials, including both in English and in Spanish, for people who have RUNX1, as well as information that we can provide to their providers and family members. And we've even been able to put together now some developmentally appropriate question and answer books for children, adolescents, and young adults to really help children understand what they have and what it means for their life, because this is a lifelong thing. There are now some clinical trials that have come on. You may have heard of some. Maybe you haven't heard of them all. One is the imatinib trial, which is being run here at the NIH by Leah Cunningham, the former medical director of the RUNX1 natural history study, looking at the ability of imatinib to alter the various parameters that we see in platelets within RUNX1 FPD. Another study that is happening is the sirolimus trial, which is being done at MD Anderson Cancer Center in Texas, with hopefully expansion to other sites soon. And this is being run by Courtney DiNardo, and you can see contact information for both here. We are actually looking at the possibility of using drugs called JAK inhibitors, and you've probably seen plenty of these on ads on the TV, as a way to also alter both the bleeding as well as some of the other side effects associated with RUNX1 FPD. And a lot of these trials have all come out of a lot of the work that's been done by Anyaprina Agarwal at Oregon Health and Science University in Oregon, and some of the work that she's done using the samples that you folks have so generously provided us. But there are many other things that we have going on. We are looking at the single cell work, looking at new variants and sequencing the platelet itself, which is an exciting idea of actually looking into the platelet biology, which before recently was always thought to be too small to really study directly. We're looking at new models, mouse models, zebrafish models of RUNX1 FPD and how those mutations interact. We're looking for genes that might reduce your risks as a result of RUNX1 FPD. And we're also looking at how we can expand access to minority and underrepresented and disadvantaged populations, both for their ability to participate in natural history study, but also making sure that they get the care that they need in their day-to-day activities. And of course, I like to finish that there are so many other questions that we're looking at, and so many of these correlate from questions that you folks raised to us when you come to visit us. And it's really, that has been what has been the driving force behind a lot of what we've been doing. And of course, I am fortunate to be one of the public faces, but this is a group effort of a wonderful group of people that I have had the pleasure to work with over the last few years and continue to work with. Of course, none of this would be possible without Dr. Paul Liu, who is the principal investigator for the RUNX1 natural history study. But we also have our clinical team, Katie and Sean, as well as Natalie, who our genetic counselor, who is also serves as one of basically a co-PI on this project. And then so many other people who help us both in the clinic, but also in the lab, taking all the information, the sample, the data that you provide us, and turning it into actionable material. And of course, it's not just at the NIH. We have a huge group of collaborators, both at other institutes within the NIH, but even outside the NIH. And of course, we have to thank all the patients and families, the referring providers, and the RRP for providing us with the information we need to make all this happen. So with that, I'll stop talking and ask if folks have any questions, and happy to answer them as they come. Thank you.
Thank you, Dr. Young. That was really great, clear presentation. Actually, in fact, someone says so much good info here. She said, wrote this really early in your presentation and was wondering if your slides could be shared or even a subset of them. Do you have thoughts?
I will have to ask.
Yeah, some of this is work that other people, right?
None
That
of
other people
none
you're
of this
representing.
is confidential, but some of this is still in the process of being published, and publications have different requirements. But we are happy to share the information that we can share, and so we'll talk about it. If we have to redact a few things, I'm happy to, but otherwise, I'm happy to share.
Okay, sounds good. So we'll follow up with everyone following once you have that figured out. So I also have a list of questions that I receive from patients ahead of time and questions that we have as well. So I have those listed, but right now I'll start with the questions that the audience has shared. So first, what causes stress in the bone marrow?
That is an excellent question, and one we're just beginning to understand. So there's a couple different forms of the stress. The stress directly on the cells is simply the fact that without RUNX1, the cells are kind of struggling to just function normally. And there's a lot of signals coming in from the body saying, we need blood, we need platelets, we need more of these things. And so the cells are kind of just under that stress. There's also, and this is one of the things that Anya Priagrawal at OHSU has been looking into, there's a lot of inflammation. And this is becoming a common theme, not just in RUNX1, but in other bone marrow failure syndromes as well, where there seems to be a lot of inflammation going on in the bone marrow. And we don't necessarily understand why this is such a common thing, but those inflammation signals also stress the bone marrow and can cause problems. Sometimes it's just because it suppresses or makes it difficult for the cells to grow, but other times it actually can introduce things like various toxins and chemicals into the bone marrow space that can be damaging to the cells themselves. And that is actually what a lot of, particularly the sirolimus study, the JAK1 or the JAK inhibitor study that we're looking into, and some of the other studies that are a little bit earlier in development, like etanercept and things like that, where those are really targeting is to try to reduce that inflammation and to really help make the cells just less stressed as a result of that. And the idea that hopefully that'll then allow them to grow, to make into the different cells. And without that pressure on them, they're less likely to acquire new mutations. And those mutations could then lead to cancer. So this is an area of very active research, and it's interesting and a very important thing, I think, that's come up in the last 5 years.
Great, thanks. And I should mention to everyone, it looks like people are typing questions into Q&A, perfect, following the request. So we'll keep going down the line. So there's a question about bone marrow biopsies and trying to figure out how to get fewer. And I think after that question was asked, I think you sort of clarified, the value and the importance of a bone marrow biopsy to catch cancer early. But someone is asking, if we give a bone marrow donation, are you able to create a clone of the cells that live forever that you can perform lots of different tests on?
It's a lovely question. I wish the answer was yes, but the answer is no. The problem is what we think is driving the cancer is the acquisition of new mutations, and so we wouldn't necessarily see those. And we do try to save we save your samples and only use them as we need to, so that they're always available. But we need to see those new mutations as they develop. And so there's not a good way to really predict what's going to happen. And I don't think I mentioned it, but in that slide where I showed that all those different mutations, the reality is everybody that we studied has mutations. It's just only about half are in those genes that we think are probably more critical. But everybody we were able to find mutations in genes that we think are unrelated. And so they just don't have effects. And so that becomes sort of the question. Did you get a mutation in the gene that's important? Did you not? Maybe that mutation actually killed the cell off, or maybe it actually gave it an advantage and then it started to grow. So unfortunately, so far, no. But we are working on it. That is the ultimate goal, is to really develop tests, criteria, and different parameters that would allow us to not have to do bone marrow biopsies, or only have to do bone marrow biopsies as the last point where, okay, we're pretty sure something's going on, let's confirm it, as opposed to we're not sure what's happening, can we take a look?
Yeah. And actually, on that vein, oh, sorry, did I interrupt you?
No, that's
Okay. On that vein, one of the questions, I'm trying to link up the questions that I received ahead. One of the questions was, has there been any innovations in making bone marrow biopsies less painful, or perhaps even doing away with them? I think the latter, the last half of that is what you just said. You hope one day that maybe we can do away with them. But in terms of pain and are there any new techniques that you've heard of?
I haven't, but I hate to say it, it's a crude method. It's an old method, but it's still the best method we have. The bone, it's unfortunate that that's where we make blood, because there are so many places in the body that are so much easier to get to less painfully than having to go through the bone, but that's really where it is. And the reason we do it in the hip is because that's actually the easiest place. That's actually not where most of the blood comes from, but we don't really have better ways to get through it. But we do try to provide as much numbing medications as possible to provide. We try to avoid too much sedation. I know people love the sedation, but sedation is not without its own risks. And there have been, fortunately, very rare, but there have been complications occasionally from sedation. But we do try to provide the what we can, and in the absolute necessity, we'll provide what is needed to be done to get it done safely, but also as painlessly as possible. You're going to be sore for a few days after. I don't know how we can avoid that yet either. But we also, using things, Amicar, Lysita, DDAVP, even occasionally platelet transfusions have really changed, I think, the amount of bruising and bleeding we've seen. And unfortunately, sometimes we just have to do it and figure out what's going on. But then as we learn, oh, when you have your marrow, we need to do these things. And it really has, I think, cut down on the amount of problems that people have had, especially after the process. So
yeah, I was wondering that, is it very personalized?
a little bit
You can't
it is.
say,
And
this is
we are tracking it. We keep track, not so
yeah.
much from a scientific standpoint, but mostly for your comfort. Well, you're someone who needs this. You're someone, when you come to us, we'll give you this. And if it changes, it changes, and we adapt. So we're trying, but yeah, it's imperfect.
Yeah. Okay. Thanks. Let's see. So, is there a way to use RUNX1 activity to estimate how pathogenic a specific mutation is? For example, for a specific family.
That is, and I, for time, didn't really drill into it deeply, but let me see if I can jump back quickly.
They said there's a bar.
Yep.
They were referring to the bar graph you
shared. This is what a lot of the work that Kat has been doing, is really trying to study it. The problem with this assay, it's considered the gold standard assay. So comparing its activity to wild type RUNX1 or to known benign mutations. It's considered the gold standard, but it's not perfect because it's limited in terms of the aspects of RUNX1 it studies. And we think, especially for those VUSs, that those stubborn ones that we haven't been able to really classify well, we're trying to develop new assays, or either assays like this that look at a slightly different aspect of it, but it's not easy to do. And there's a lot that goes into it because this test, as simple as it looks, it's actually not. It's actually a huge panel every time we run it because we need all these different controls because ultimately this is considered a clinical test that's been developed and it's a great, powerful tool. But making these tests requires a lot of checks and balances and controls to make sure that the information we're providing is correct and as accurate as possible as we can possibly make it. So we are looking into those. This is probably the best one. And when we find something, we do let the family know. I believe we've now reclassified between 5 to 10 different families based upon these kind of assays or other similar assays that have served as secondary data.
Great. We are getting a lot of really good questions. So let me see if I can collate some so we can get to as many as possible in the next 5 minutes. Let's see. Is there this related to the lifestyle? I thought that Dr. Young, I was really happy to see the lifestyle suggestions and, sort of how to think about things at home, because a lot of the questions we've gotten in the past leading up to this was how to sort of manage and what to watch for at home. But someone asked, is there a way to reduce the stress, inflammation, and the bone marrow through lifestyle choices as you might with other kinds of stress, or is that not how it works?
I wouldn't say it's not how it works. The problem is I don't think it works. It's not as clear cut as that, unfortunately. Because I know like there's things like certain conditions where you do a ketogenic diet, or you can like celiac, you cut certain wheat and the wheat protein out of your diet, and that really reduces it. We don't really, the problem is, I think one of the problems is we don't know exactly where the inflammation signal is coming from. We're getting closer and closer to it, but we don't know what it is. And the other problem is, and this is probably even as we get to understand it more, it's a multifactorial thing. So there really isn't a specific lifestyle or a specific diet or habit change that is going to help. Now, things I can say, smoking is associated with pretty much every cancer you can think of. So really reducing that is an important thing if possible. And I think a good example I like to give for smoking is we always think about lung cancer and the heart disease because that's where the smoke goes. Bladder cancer has been associated with smoking. And how do you get from the lungs to the bladder? It's only by it circulating through your entire body. And so that can have impacts in other places too. So we know smoking is a big one. Weight loss, and I count myself as slightly hypocritical on that, is an important one as well. We all struggle with it, but probably weight loss has been associated with cancers. And so we think things like that, lifestyle changes, good exercise that have been just associated with reduced risks of other types of cancers probably do play a role in how leukemia and the other blood cancers develop. But we just don't have a specific one-to-one like we do in certain diseases and disorders.
And quickly, relatedly, someone's asking, like, so you were talking about cigarette smoking. I assume
Yes.
someone's asking about marijuana smoke. Would that be a similar mechanism, or is there less known?
I think it's less known. Presumably, yes. I mean, you're basically smoking an herbal leaf, and that's creating similar carcinogens. Now, the different things, it's hard to say. Yes, I think smoking. I would say smoking is the thing. And then
Whatever it is.
that brings in the questions of things like vaping and stuff like that, and those have their own questions. And to be honest, that's a little bit outside my knowledge base or my ability to really answer definitively.
Yeah, that makes sense. Okay. This might be okay. I'm aware of the time. Let me ask you this question. Do you have a hard stop, or do you have a little extra time?
I have time.
You have time. Okay. So if you don't mind, maybe we can stick around for another 5 minutes or so. Apologies if those who asked questions have to go, but we'll try to get to these questions that are here now. And then if we don't get to everything, we'll follow up. But
Happy to.
thank you. I forgot to ask you that ahead of time.
That's fine.
So feel free. Has the list been published of what specific mutations/deletions are pathogenic versus benign?
Yes.
Yeah.
In a couple places. One is obviously in the paper, and when we publish the updates, they'll be in the paper too. There is though a database. I'm sure you if you folks at RP are aware of it, but maybe not the general population, called ClinVar, where every mutation that has been annotated and studied and analyzed is published. And so it lists the mutations, it lists the specific changes, it lists the attribution, whether it's pathogenic, non-pathogenic, if it's likely, not likely, or if it's a VUS. It even gives the supporting data and how that decision was made. It doesn't quite dig into the weeds on that, but it gives the supporting information. And that gets updated probably even that more frequently even than the publications do, because the publications come out every few years, but even as we're going along. Now, the publications help inform that, because if it is published, that obviously is something that maybe if it wasn't in the database will get captured. And this is an area that Natalie here has been, but also people like Lucy Godley and others have been very active at making sure that as we learn new mutations, as we classify them, as soon as we have the data that supports it, we get it over to the committees that's responsible for that, so that they can update these classifications in ClinVar and make sure that not only the families, but everybody who might encounter them, so doctors, genetic counselors, everybody really will know, and going forward too, so that it's constantly being updated. That's probably the best place.
Yeah, we do. We do use it quite a bit here, so I can send that link out. It's tricky to get used to, but once you do, it has a nice.
It's most user-friendly. I will admit.
But we can certainly send it for those. We have some savvy patients on this in this group who can figure it out. Okay, let's see. So one of these is pretty specific. When considering other gene mutations, how much study has been done on DDX41 as related to RUNX1? Or is your group looking at that a bit? Or
we are not. So DX41 is definitely on our radar. It's certainly on all the panels that we study when we look for mutations. This is something I know that Dr. Godley has been very active in promoting and driving awareness of, and it's an important question. I think right now there is some ancillary studies and things looking into it. It's not like one of our primary projects, but it is something that is on the back of our mind and things that we have considered. It's hard because basically those are two, we think, pretty potent genes in terms of risk factors for cancer and things like that. And putting them together is probably not a good combination. But DDX41, we're still just teasing out in terms of the overall risk, and so how the two of those would interact is probably an important question, but we don't really know that yet. And that's probably going to require just the natural history study itself and similar studies aging up and maturing, and as we get more and more data and follows longer. Because whereas RUNX1, I think the signal's a lot cleaner and a little bit quicker in terms of when the cancers and things happen. DDX41 is sort of a longer lifetime risk, and I don't think we just have that data yet. But it is something that is on our radar, and we do consider it. Or Lucy would call us up and yell at us.
Right, certainly. So I thought this is a really good question. With all the clinical trials coming on, there's so many factors patients think about when they're choosing between the two, but we have a couple available now, and then the JAK inhibitor work that you have coming up. Is that a quick explanation on, can you explain how it works? Or
it works similar. It's a similar idea, that the idea is attacking the inflammation signal. It's looking at a slightly different arm of how inflammation works. Sirolimus is looking at one. And in fact, when we were first originally thinking about the studies, we kind of had to make a decision, which one do we go? MD Anderson went with sirolimus. We're looking at the JAK STAT pathways instead. The idea is by disrupting it, you help reduce the inflammation. And this has actually been seen, and one of the promising things that we're hopeful with the JAK inhibitors, but we obviously need to test them, is that these have been used in other bone diseases like myelofibrosis, MDS, and things like that, where it is actually given and can help improve counts. Sometimes you can help change diseases. And then the other maybe add-on benefit that we don't is sure about, though, is these drugs have also been approved for things like plaque psoriasis, psoriatic arthritis, and certain types of rheumatoid arthritis and things like that. And so potentially we could also be attacking the inflammation of RUNX1 at that standpoint too. And so that really is sort of our goal, is to see whether or not what effect it has on blood, as well as what effect it is going to have on these other symptoms for people who have them. That's really about as much as I want to say, just because I don't want to, because we're still early on the development. It's not like some great secret. I just don't want to promise things that we haven't really been able to figure out exactly how that's going to all come together. And that's actually going to be a point of discussion at the RRP meeting in a couple of weeks too. So is what's the best way to look at that.
Okay. And hopefully, and I'm putting you on the spot, but hopefully you'll be open to us offering a webinar when you're ready to talk
Sure.
about
Yeah,
it
no,
more
well,
in depth with
we've
patients,
learned
right?
that from other diseases that I've studied. I've learned that if taking people up on that offer is the best way to reach the people. So no, we'd be crazy not to.
Perfect. Okay, thanks. Okay, two last questions if you
Okay,
have the time.
sure.
Are there any it's going back to the bone marrow biopsies. Let's see. So, are there any long-term risks for starting bone marrow biopsies at an early age, like 3? And relatedly, you had said important to start them when it's sort of safe to do so. And I was curious about what's the safe level, and then relatedly, long-term
So the
risks.
there's two elements of the safety in terms of doing it at a young age. Now, I have done bone marrow biopsies, I hate to say it, on babies, and that has one that's had to be done for kids who have leukemia, and those are unfortunately sad cases, but we can do them safely. We can do them. But it is a sedation, and we know we don't understand all the risks, but the developing human brain, especially in the first year or two of life, is very sensitive to the anesthesia and things that are required. And for a child, you have to put them to sleep to do the procedure. So we don't like to expose kids to that needlessly at a young age unless there's a really strong medical indication. So if I had a child with RUNX1 who had weird counts and things were going crazy, I wouldn't think twice about doing it, regardless of the age. But if it was someone who was otherwise healthy and doing well, I wouldn't want to do it before they're about 3 or 4. And 3 or 4, that number is a little bit arbitrary, but it comes from both the age. We know that at that point, things are not obviously you're always developing. You're developing until you're into your 20s, really, but things are really have settled down a bit, and it is much safer to give these things. But also, it's just easier because the kids are bigger, and you reach a limit, and it's usually around the 15, 20 kilos is sort of an area where people feel much more comfortable doing sedation for children. So that's sort of the thing. In terms of the long-term risks, we don't think there are. I can't say that there isn't an impact of doing the bone marrow biopsies. The bone heals. So it's not like you're going to permanently have a hole in your hip. We have people on other studies where we've been doing bone marrow biopsies on them for years on end, sometimes several times a year. So they've had 15, 20, 30 bone marrow biopsies, and it's fine. And every time we do the biopsy, we can see the blood cells. So everything that's there, it fills back in and it fills up the space. So it's not like your hips are falling apart, but I can't say that there isn't some effect on it. But the area we talk about doing it in the hip, it's actually sort of the back of the pelvis bone. And it's a part of the pelvis that's very stable, and it's not part of the leg itself. Actually, it's not part of the joint. So I wouldn't say it's a useless piece of it, but it's a very strong and kind of just durable, rigid structure that really does just grow back. And so it shouldn't cause any lifetime disabilities or anything like that. And it's not near any of the major nerves or arteries or vessels either. So the risks of bleeding and nerve damage are low. Never zero, but very low. So we don't think there's a risk to it. This is one of the questions that will come up with the consensus guidelines is probably what ages will we recommend? But that's been sort of our recommendation going from our group. And other groups have said similar things. And I think also speaking with people in the communities, that's similar things. So I suspect that will ultimately be the decision if they actually say an age, be somewhere in the 3 to 5 range.
Okay. Yeah, great. We're really excited about those coming around soon. Okay, last question. Thank you for your extra time. Would you suggest? I think this is specific, but I think it's helpful for families. Would you suggest a bone marrow biopsy for an active runner / teen RUNX1 patient whose blood work looks fine, but fatigue and weight loss has occurred, or does the blood work really direct a bone marrow biopsy only? If the blood work looks fine, would you
No,
push?
that is a good question. And obviously there's a lot of parts to this question, and it seems like there's a specific question. And I'll also say is I can't even tell even from looking back, I don't know who this is,
Yeah.
but if this is someone who would like to directly reach out to us, we're happy, and you can see my number, my email there. We're happy to take your question directly to us. I mean, you might be able to provide us better information, but the blood work is probably chief, like it's the biggest thing. And if the blood work looked stone cold normal, I would be hard pressed to do it. But if there was unintentional weight loss and fatigue and things like that, I would want to do maybe not necessarily a bone marrow biopsy, but a head-to-toe evaluation
Yeah.
of things like the endocrine system, like the heart, like the lungs, looking at different things. And that ultimately might include a bone marrow biopsy. It's probably not the first place I'd rush to, but it would definitely include a CBC with a full looking at all the different blood lines or cell lines in the blood, even having someone looking at it under a microscope. So this story, depending on how bad the fatigue is and how big the weight loss is, this story could end up in a bone marrow biopsy, or it might just need some extra blood work. And you'd be like, oh, look, your thyroid is a little bit off. And we see people with thyroid problems, both because that's a common thing in the population, but also we do see it in our group as well, or maybe something else too. So there's a lot of things that can go into that decision. Um, um, but yeah, I think it's still the gold standard. If we really don't know what's going on, we have someone with RUNX1, especially if someone has a strong family history of it, because as I mentioned, it is variable in the families. But if there's particularly history of younger adults or even children having cancer and things like that, I'd have a lower threshold. So it's
Yeah.
not the be all and end all. I would say it's neither yes or no. So even if I had as a perfectly normal CBC, I'd be a lot harder pressed to justify a bone marrow biopsy, but I wouldn't necessarily say absolutely not. And then on the flip side, if I had these things, sometimes I would. So it's very variable, but yeah, no, it's not black and white.
Yeah. Okay, that makes sense. And I would say that that's one of the positives we always promote about your study, or patients promote to each other
Mhm.
about your study, is that having you all sort of as second opinions for things like this, when you know the whole situation, is helpful, right? You can play a role in sort of connecting with their physicians at home. Is that true?
Yeah. Oh yes, definitely. And
Yeah.
I don't think it's something I stress either. There are even people who get their bone marrow biopsies done at home for either logistical, money, whatever reasons.
Yeah.
And a lot of times we can get those samples sent to us and we can look at them and offer our thoughts too. So we're working with them on many different levels, and it's been very, very fruitful interactions. And I think that's really the only way, because while we are looking at doing clinical trials and doing studies and things like that, and we love seeing people every year, ultimately the people doing most of the work, taking most of the care of our patients with RUNX1 are the local doctors, are the local hematologists, are the local nurse practitioners and PAs. And so really they are the eyes and ears. They're the first responders. They're usually the treating people, and we're all the ones offering the advice and recommendations, but we're not ultimately the ones doing most of the treatments at the moment. So we wouldn't be able to do anything without that communication, and that's been so critical to all this.
Well, thank you for all your extra time. Thank you to so many people who were able to stick around and ask great questions. Hopefully, everyone's curiosities so far have been answered. But as Dr. Young described, we have a close relationship, and obviously we keep up with things, and we'll have you around again, hopefully with your JAK2 inhibitor up and running
We'll
at
see.
some point. We'll have you on again.
Yep.
Thank you so much for your time and your great
Thank you
presentation.
for having
Very,
us.
very helpful. And we'll follow up with others after the webinar.
Like I said, our information is there, and we're always happy to take questions.
Great.
All right.
Thank you. Take good
Bye.
care. Bye bye, everyone.